I'm Jim Spicher. I'm the medical director here at St. Anne's, and back for another installment of respiratory viruses. If you recall, during the pandemic, we did this, it seemed like every couple of months as we were figuring out what to do about COVID. So I decided this time that we would broaden it a little bit and talk more broadly about viruses other than COVID, but also including COVID. And particularly what that means for us in long-term care. So there's over 200 different viruses, respiratory viruses that affect humans. I listed here just some of the more common ones and some of the ones that cause significant illness. The first three, RSV, COVID, and influenza, are ones that probably cause the greatest severity of illness and hospitalizations. The next two, para-influenza and metapneumoviruses, these are respiratory viruses that in vulnerable populations, people who have lung diseases, often young children, can cause serious disease, but often for you or I, or generally healthy people, they may just cause colds. The last two, rhinoviruses and adenoviruses, they basically cause the common cold, at least half of the common cold. There's a lot of other viruses that we're not going to talk about. And why is this important? It causes a lot of illness in a given year. It's estimated that about 1 million hospitalizations per year in the US and up to 100,000 deaths. So it is a significant cause of mortality and morbidity. And it seems that for many of these viruses, they tend to peak during the winter. And you might ask, why is that? And it's thought that it's not because of the temperature. It's not because of cold weather. It's because during cold weather, we all get together and stay inside, and we get together for holidays, and we spread our viruses back and forth to each other. So in the tropics where they don't have cold weather, these viruses tend to be more prevalent during the rainy season when everybody's inside and together and spreading viruses. So it's not the cold, it's just the fact that we get together during the winter, and it's easier for the viruses to go from person to person. So if we look at respiratory illnesses this year in the United States, the CDC tracks these all the time, and if you have any interest, you can go to their website and actually see what's happening in the country. As you can see, in Pennsylvania now, respiratory viruses are starting to ramp up a little bit. We're at the moderate range. A lot of the country is low to minimal respiratory viruses. And so how do they track these? They look at things like emergency room visits and what kind of viruses are detected during emergency room visits. And as you can see, during the past year, in 2024, during the winter, you have flu, COVID, and RSV. And this is what we just got through here this past August. That's COVID that tended to peak in the summertime. If we look at what percent of the respiratory viral tests that we do during a given year, you can see similar trends that there's a lot more of it during the winter. And you can see how long we had flu last year, all the way out into almost May. And then again, we had another peak of COVID in late summer. Typical symptoms, we all know those. Cold symptoms, a lot of cough, body aches, headaches, weakness, chills. What is different for our residents is that they may not have a lot of these symptoms. They may just be weak and tired, or acting a little strangely, not wanting to eat or drink. Maybe we'll see more falls. So the typical symptoms that we might experience with respiratory virus, we may not see with our residents. In long-term care, if you could construct a scenario that would be sort of the perfect storm for respiratory viruses, I think it would be long-term care. So you put a lot of people who are elderly with compromised immune systems in a small area, and they can pass the respiratory viruses back and forth. And then we have co-workers, we have staff that come in from the outside, and they bring, and family members that are visiting, and then they bring viruses. And so it's a difficult environment in which to protect our residents because of just the logistics. If you think about it, a lot of our workers are younger. They may have younger children at home. Their children go to school, they go to daycare, they bring viruses home. Parents may come to work not even knowing they're sick and pass along the viruses while they're here at work. Conversely, workers could pick up a virus from a resident while they're here and take it home to their family. So there's this back and forth where the viruses can move from home to school to long-term care facility. So you have to kind of think about how's the virus circulating in the community and what are the impacts of that for long-term care. So how do we prevent that? We prevent it by trying to prevent the transmission of the virus. We do that by making sure we're washing our hands so we're not transmitting the virus that way. And we do it by wearing masks. One thing that we learned during COVID is that wearing masks decreases the transmission of viruses. So it lessens the chance that an employee is going to transmit something to a resident, and it also lessens the chance that a resident is going to transmit something back to that employee. Very important that if you do feel sick or ill, that you don't come to work and bring the virus with you and pass it on to our residents. We also learned during COVID that it makes a difference if we can bring fresh air into the facility. We can filter the air and decrease the amount of viruses circulating indoors. And of course, the importance of vaccination. This is a way for us to decrease how often we get sick. If we come in contact with these viruses, our immune systems will be better able to fight off the virus and prevent us from getting ill and passing it on to our coworkers or to our residents that we're taking care of. Just a graphic of what happens when we sneeze. And think about all the viruses that get expelled whenever when we cough or sneeze, and that's how these viruses go from person to person. And you can imagine how helpful a mask might be in this situation. So let's talk a little bit about influenza or the flu. There are two basic types. We call them A and B. Type A is the type of flu virus that also can circulate in animals. So we see it in birds, we see it in pigs. Those are probably the most common ones. And this is important because the virus, when it goes through another animal, or is actually an animal virus, and then comes in contact with a person, the viruses can then mix, and sometimes a mutation can happen and a new virus can emerge, and that's what is then the beginning of an epidemic, because whenever we see a new virus, something we haven't seen before, that's when we're vulnerable as a population. So you hear about bird flu, you hear about, actually recently, bird flu getting into cows. You've probably heard about that. So this is something that's kind of always looming in the background and always a concern for the epidemiologists and the virologists who study this, because this is where the next pandemic is likely going to come from, and that is a flu virus that came from a pig or came from a cow, got into a person, mixed with another human virus, and then was then able to go from human to human, but it's a new virus. So type A is the one that we worry about in terms of future pandemics. Type B, generally milder, only affects people. So typically we see A earlier in the season and then B later in the flu season. Depending on the year, flu can cause quite a bit of mortality in the country, anywhere from 16 up to maybe close to 100,000 deaths annually. Most of those are in very young children or very older adults. I thought this was interesting. I'm a little geeky that way. But this is a graph of flu-like illnesses in the country in different years. So this is the graph this past year. So it's a percent of outpatient visits for respiratory illnesses, flu-like illnesses. So typically you would expect, and this is the end of the year down here, so this is the winter time. So that's about when you would expect flu to be peaking, okay? What's interesting is this line down here. Anybody know what that is? What year that is? COVID. That was during the height of COVID. That was the first winter of COVID. So this is when we were all staying in our houses, wearing masks, not going out, and look what happened to flu. We didn't have any. So just another example of how those precautions that we were taking affect other viruses other than just COVID. And so they work for other respiratory viruses as well. But it's pretty striking, I think, how little flu we had that year because of all the COVID precautions. Typically, flu hits you quickly. People say, I feel like I got hit by a Mack truck. I was well this morning, and this evening I feel terrible. Every bone aches, my head is pounding, I'm having chills. That's typical of flu. It comes on quite quickly. Again, in the elderly, may not be quite as dramatic. We may just see weakness, confusion, lack of appetite. The thing about flu is that after an infection, there's an increased risk of getting bacterial pneumonia, so we have to be on the watch for that. Someone who's getting over flu and then gets sick again, it may be a bacterial pneumonia that has come about. We diagnose flu similar to the way we diagnose COVID with little nasal swabs. There's a rapid flu test that likely you would get at your doctor's office or the emergency room, urgent care. Get the results in about 10 or 15 minutes. It's pretty good, 50 to 70% sensitive, so it does miss some cases. The DNA test, the PCR test that's done in hospitals is much more sensitive, less likely to miss things. During the midst of an outbreak, it's really not necessary to even test, because if everybody's coming in with the same symptoms and there's a lot of flu in the community, chances are that's probably what it is. And so a negative test during that time really isn't going to mean very much, because it almost always is flu. In terms of treatment, we have one drug, basically, for flu, Tamiflu. There's another IV drug that is used for people who are hospitalized, but for the most part, for our residents here and for people in the community, there's one drug that works to lessen the severity and lessen the duration of flu symptoms if you started early. If you wait till day 3 or 4 or 5, probably it's not going to be much benefit. It is a safe drug to use during pregnancy, and pregnancy is a time when people are particularly vulnerable for complications from respiratory viruses, so don't need to be afraid of using it if you come down with flu during pregnancy. In terms of the flu vaccine, we would recommend it for everybody over 6 months of age. Infants really can't make antibodies, and so Infants less than 6 months of age really can't benefit from vaccinations, but everybody else 6 months and up is going to have benefit from a flu shot in terms of decreasing the severity of illness if they're exposed, and if they're elderly, it also decreases the risk that they could actually die from the flu. One thing about the flu virus, and certainly we're learning this about the COVID virus, is it changes. So the virus mutates, the virus changes its characteristics, and so each year there's a group of people that get together and they look at all the different strains of viruses that are circulating around the world at a given time, and they try to predict what is going to happen during a particular flu season. So last summer, they made a decision about what type of flu viruses to put in this year's flu vaccine. And they generally are pretty good. Some years they miss. But the important thing is that you really need to get a flu vaccine every year to get the most benefit so that it will match the virus that happens to be circulating that particular year. The RSV, we've heard more about RSV because there's a vaccine available now when you see advertisements on TV. It's an important vaccine for children, an important virus for children because it causes a lot of illness, particularly with infants. But it also can cause a lot of illness in the elderly as well. For most people, it's just kind of a cold, but it can progress in people who are immune compromised and in infants to cause pneumonia, wheezing, shortness of breath, and many times requires hospitalization. We don't really have any viral medications for RSV. So it's kind of supportive care. The important thing is we do now have a vaccine, and it does benefit seniors. It keeps them out of the hospital. It reduces the mortality rate. And so the good thing about it is it's a one-time vaccine. It's not an annual vaccine. So anybody who has respiratory problems over the age of 60 or anybody who's over the age of 75 should and would benefit from an RSV vaccine. COVID. We have had lots of talks about COVID, and everybody probably is tired of hearing about COVID. It's still with us, although in a little bit different form. It started, as you recall, back in end of 2019, beginning of 2020, so we're coming up on almost 5 years that we've been living with it. In this country alone, has caused about 1.2 million deaths, and it was disproportionately affected our seniors, particularly those in long-term care. Seniors in long-term care account for about 10% of the population in this country. They accounted for about a third of the deaths from COVID, so it really affected seniors. Unfortunately, we're not seeing those kind of numbers these days. We talked about how remember we talked about COVID variants at the beginning. There's alpha and beta, and at first we paid attention to those. Well, now we're out to about the 8th generation of COVID variants. So there are hundreds of variants now, and they keep evolving and keep changing. So this is why you need to get a booster every year, because the COVID booster, the COVID shot that you had way back here isn't going to really help you when the virus is way out here in a completely different virus. So each year it's a good idea to get a COVID booster because they change it each year to try to match where the virus is going as it evolves, as it changes. This year, we've seen COVID. There's been a lot of it around in the community. We've had a fair amount of it here at St. Anne's. The good news is people aren't getting nearly as sick as they were at the beginning. People are not generally having to go to the hospital. People are not generally dying from COVID. Again, it takes about 3 days after exposure to catch it. Often we're just seeing runny nose, headache, body aches, maybe weakness, fatigue. Rarely are we seeing the respiratory failure and pneumonia that we saw early on during the pandemic. This graph, I think, is pretty interesting. These blue strips are weekly deaths from COVID. This is the beginning of the pandemic. This is the first winter of the pandemic. This was the worst. The pink line are the number of positive tests. So that is kind of how much COVID is circulating in the community. What's really interesting, I think, is look at the death rate and how it has gone down. And yet the amount of COVID in the community is still there. It's just that people aren't getting as sick, they're not dying from it. So I think it's a pretty dramatic difference in terms of what we're seeing with COVID. And again, there's kind of a winter peak and then a summer peak, winter peak, summer peak. And here we are. This was our little peak in the, and actually you can see, there was quite a bit of COVID positivity this past summer. The number of positive tests in the community was really pretty high. But what we didn't see were many deaths. So that's the effect of vaccination and the effect of people having been exposed to the virus before. So it's just not making people as sick as it did at the beginning of it. In terms of treatment, we have 2 oral medications that work pretty well. Paxlovid probably works a little bit better than molnupiravir. I like to recommend them for all the residents who come down with COVID because it does decrease their risk of having to go to the hospital or have severe complications. Not everybody needs to take these medications if they have COVID, but we offer them to people who are high risk for complications. If people end up in the hospital, we have IV medications for COVID, one called remdesivir. We also use steroids to also help reduce the risk of complications. Long COVID basically means that you continue to have some kind of symptoms 3 months after you've had COVID, that they just aren't going away. And fortunately, we're not seeing as much long COVID as we saw at the beginning. Early on, there was up to 10% of people who got COVID ended up with a long COVID symptom. Now it's probably more like 3%. But these could be just overwhelming fatigue, palpitations, rapid heart rate, dizziness, lightheadedness, just a brain fog where people have trouble concentrating. They feel sort of dopey and not able to focus. I'm sure most of you are familiar with people who have lost their smell or taste and they don't get them back. Some people have chest pains. So we don't really understand exactly why people get long COVID, and we don't understand how to treat it at this point. So there's a lot of research being done in this area. A lot of people do eventually recover, not everybody, but there are literally millions of people out there in our country now that continue to suffer from the long-term effects of COVID. Fortunately, it's not as frequent. We know that people who are vaccinated tend to have fewer episodes of long COVID and less severe ones. So hopefully at some point we will have a better understanding of what causes long COVID and how to treat it. This past year, the COVID vaccine reduced hospitalizations and ER visits by about 50%. They actually looked at the vaccine to see how effective it was. In long-term care residents, it's only about 30%. So again, the population in long-term care isn't able to benefit as much from vaccination because of their immune systems. But it does definitely reduce the risk of being hospitalized and having severe disease. So it's still very effective. Similar, I think it's kind of similar to what we would see with flu in general in terms of effectiveness. So the bottom line is these respiratory viruses are all around us. They're going to be with us. They keep changing. Preventing them is really the best long-term strategy. And that is doing things to try to prevent the spread, making sure we're washing our hands, making sure we're wearing masks, making sure that we get vaccinated, trying to do whatever we can to reduce the opportunity for the virus to travel from one person to another. The things we learned during the COVID pandemic are useful to us now to help us prevent other respiratory viruses as well, because they're all kind of transmitted in the same way. So the things that help us prevent COVID transmission also help us prevent flu transmission or RSV transmission. You think back about that slide to see what happened to flu during the COVID pandemic. All those COVID precautions helped with flu as well. And again, the population that is most affected by these respiratory viruses are our seniors. And so they're the ones that really benefit the most from our efforts to prevent transmission. So I put this slide in here just to remind us, who are we here to serve and why it's important that we do these things to protect the people that we're taking care of. That we do all that we can to protect them and enhance their well-being. Because in many ways, the actions that we take as individuals in terms of making a decision about whether we wear masks or not at work, whether we come to work when we're ill, whether we get a vaccine, those individual decisions we make do have implications for the people that we take care of here at St. Anne's.